Good morning, everybody. Thank you so much for being here, virtually and in person. Welcome to the board of Health for Louisville Metropolitan Health and Wellness, online viewers to the March 2026 meeting. The Board of Health meeting is officially called to order at 7:37. This meeting will be streamed live via YouTube and then will be rebroadcasted through Facebook. The January meeting minutes were not voted due to the lack of quorum. So they were distributed as a package along with the February minutes. Please remember that in compliance with the Open Meeting Act, guidelines that states every voting person or member must be seen and heard. Are there any discussions or amendments for the January minutes? If none, may I have a motion to approve the minutes as dispensed?
So moved.
May I have a second?
Second.
Thank you very much. All in favor, please raise your hand and say aye.
Aye.
Aye. Any opposed? Any abstentions? If not, I motion to approve all the January minutes as distributed. Now we have to go to the February minutes. Are there any discussions or amendments to the February minutes? If none, may I have a motion to approve the minutes as dispensed?
So moved.
May I have a second?
Second.
Thank you. All in favor, please raise your hand and say aye.
Aye.
Aye. Any opposed? Any abstentions? If not, we have a motion to approve the February minutes as distributed. Thank you very much. Now we go to the chair business. March is Women's History Month, and so it's ad hoc that we have the Office for Women for Louisville Metro today. And remember, we celebrate the contributions and achievements of women throughout the history, not only in the nation, but in the whole world. National Nutrition Month is also for March. It's gonna focus on healthy eating habits with the 2024 theme Beyond the Table. So it's not all about what we have at our table, but how we produce it, and that is very important. It's also the Colorectal Cancer Awareness Month, highlighting the prevention and screening that is important, and is represented by blue ribbons. This is also the Red Cross Month. Let's remember and honor the work the American Red Cross does for our country, but around the world. And it's also the Developmental Disabilities Awareness Month, promoting awareness and inclusion. We have several and other awareness and more specific celebrations as well. This week, March 1st to the 7th, is the Severe Weather Awareness Week in Kentucky. Remember, severe weather can occur any time of the year and can bring many different hazards, and we know it and impacts the whole region. Severe Weather Awareness Week is your reminder that we need to be prepared. So we need to be ready for hazards such as tornadoes, severe thunderstorms, large hail, lightning, heavy rain, flooding, and high winds. The National Weather Service, and particularly in Louisville, will feature a day dedicated to every single one of these awareness of or weather-related problems that may arise. So please pay attention. They will also have a dedicated beach safety day, since the spring break is coming and many of our community members will go to beaches, and we don't know how to confront hazards related to weather, because we don't deal with those on a regular basis. Also remember, today is at 10:07, there will be a weather alert system test. It's gonna be through the whole county, And if you have the alert in your phones, it will be triggered. And as we read in the director's report, the upper respiratory viral infections are still going on. They are low for COVID and flu. And the type A virus infections are switching little by little to type B. Remember, RSV transmission can be reduced by maternal vaccination and also by the use of antibodies for babies born during this period. Kentucky Department of Public Health also reminds us, along with Louisville Metro Public Health and Wellness, we have learned all the preventive measures to reduce the impact of these infections. Now we got to our perspective session, and we will have this month Louisville Metro Office for Women and the public health activities the office has. The presenter is the Louisville Metro Office for Women Director, Ms. Gretchen Hunt. Squire. She has spent her life advocating for women and for an end of gender-based violence. She currently serves as the director of the Mayor's Office for Women, where she leads efforts to raise the status of women and gender-diverse individuals through education, programs, and policy. Under her leadership, the office launched the Office for Women Ambassador Program, a civic engagement and leadership program that includes women and gender-diverse individuals from all 26 Metro Council districts. She has led efforts to pass legislation granting all Metro employees who are victims of domestic violence paid leave, a policy that has recently replicated in Lexington, Kentucky. She has done this and many, many, many other things. We will share with you her bio. She has served previously as an executive director of Emerge Kentucky, director of victims advocacy in the Kentucky Office of the Attorney General, a staff attorney for the Kentucky Association of Sexual Assault Programs, a staff attorney of the Cabinet for Family Service Office of Domestic Violence and Child Abuse, and immigration attorney at the Center for Women and Families. So many notable accomplishments. Today, I welcome Ms. Gretchen Hunt. Please, I yield the floor to you.
Thank you, Dr. Patty, who is also, we are so lucky to have an ambassador this year. So bridging all these circles of great work happening in this city. So good morning to you all. I want to first say, I'm going to take a point of privilege and just give respects to my father and mother who have shaped me to do all the advocacy that I do and who are also medical professionals. So my father taught at the medical school for many years and worked on infectious disease and virology. So I'm a good vaccination champion. And my mother is a retired pediatric nurse practitioner. So although I'm a lawyer and I do try to speak public health and was certainly raised up in it and really appreciate and honor all the work that you all do to keep our city safe and strong. So I just wanted to take that minute to thank them for all that they do. So a little bit about the Office for Women. Catalina, you can go to the next slide. It's been in existence since 1991. And a lot of folks don't know that, but over time it has shifted in different forms. And 4 years ago when I came in, and it wasn't due to me, it was due to the advocacy of Tina Ward Pugh, my predecessor, who many of you know. She advocated for it to be moved back up into the mayor's office in the Office of Equity, which is really excellent because it removes it from thinking that women's issues or gender issues are separate. They really should cascade across all of government, because whether you're talking about transportation or vaccinations or housing or economic development, there are gender dynamics in every unit. So one of the things that I want to just talk about briefly is a broad overview of an office. Our mission is to raise the status of women and gender diverse individuals. That means people who may identify as non-binary, who face many of the historical and current discrimination or barriers that women face. But we also promote gender equity as the norm in Louisville. And that's the invitation in for men to see their lives and well-being as represented in this office. So I say that to say that gender equity, a simple definition, is that you have equal rights and responsibilities between men and women, which means that our office advocates as much for policies like paid parental leave, that in fact in Louisville, in our city government, have benefited more men so far. More men have taken advantage of that policy. And the research shows that when men take paid parental leave, not only do they bond with their children and experience their full humanity, but it actually reduces the burden of unpaid labor that women face over time. That burden is shared, and it reduces child abuse and domestic violence. So there's all these great benefits. So if I'm doing my job right and the Office for Women is doing our job right, it will raise the status of everyone. And we also have programming that addresses men's issues. So I'll talk about that in a minute. But I have 4 broad priorities that guide the office. Of course, they are all in service of the mayor's goal for a safer, stronger, healthier city. And so I feel like this keeps happening. We did a night walk last night and I had to take a pause like at Shakespeare at the Park, but you hear the plane outside. But there are 4 main priorities that guide the work, because as you can imagine, there's so many things to do for women in this city. And I'm a one-person office, so I have to work very strategically through collaboration. But the 4 main priorities are economic empowerment, knowing that there's still gender wage gaps. When you look at poverty in this city and you really zero in on the data, you're really looking a lot at single moms in the city. And to be specific, African-American single moms in the city, Latina single moms in the city who are experiencing the most economic hardship. So we look at avenues to raise the status of women economically. Community engagement and civic engagement. This is where the Office Ambassador program lies, which is a 6-month leadership and civic engagement program intended to grab women from all over the city, from all 26 council districts, to learn more about how city government works. The idea being that then they can distribute that information out there. That shouldn't be news to you all who know the context of community health workers or peer educators. That is very much a public health model, getting the word out and having this communication loop with diverse women in the city. We also do an Office for Women Connection, a 1-day training that's this Friday. And then for the first time, we started last summer, Office for Women Allies, a 1-day training for men to invite them in to talk about men's mental health, men as caregivers, and men standing up to prevent violence against women. So that's the array of programs to engage the community in this work. Gender mainstreaming is a 3rd priority. How many people have ever heard the term gender mainstreaming? Aside from maybe Carmen. So it's one of those wonky words. It really just means that everybody should be thinking about it, gender equity, no matter where you're sitting. And by that, I mean, whether you are doing say during COVID, I was not working in the governor's office at the time, but I still had a relationship with him. So I was messaging very quickly when he started doing his press conferences about being safe at home, to also message in that if you're experiencing domestic violence and you have to be home, here's those hotline numbers. So for example, that's a gender approach to a safe at home policy during COVID. So that's an example of how you want to think about gender equity wherever you are. It's really just making it the way that you do business rather than a separate issue. We often siphon off women's health or women's issues as being grouped in maybe maternal health, reproductive health, sexual violence, domestic violence. But in fact, our issues are everything, right? And we're learning now that because there have been so many blind spots, for example, in medicine and other places, we've not understood health approaches that really work to benefit women. And the 4th is gender-based violence prevention. So that means anything from sexual harassment to domestic violence to sexual violence to trafficking, and thinking of innovative ways. You want to switch to the next one? So I'm going to just flip through these pretty quickly. I am tasked by the mayor to help recruit more women to non-traditional fields, including fire and policing, in order to have a more representative fire service and police force. So that's some of the work we do. Catalina, if you can go kind of quickly to the, let's see, the gender-based violence prevention. I'm going to go through this quickly. Next, 2 more slides. Okay, 1 more slide. Okay. So I do want to highlight some of these. Back one. I'm jumping all over the place. I want to talk. Or actually, this is fine to start. So one of the first, I think, most successful things that we have done is our paid leave policy. So if any of you all have been in the bathrooms or the elevators and you've seen those signs that say, is your partner doing anything that makes you feel unsafe? There may be resources. That's part of a paid leave ordinance that our office worked with then Councilmember Cassie Chambers Armstrong 3 years ago to pass. And it's 7 days paid leave. You can go to the next slide, Catalina. It's 7 days paid leave for Metro employees, about 5,000 people. Now, the goal of this policy is absolutely a public health model. Setting out a policy sets a norm for a workplace to say this behavior is not tolerated here, and we will surround around victims to help keep them safe. It reduces health impacts of domestic violence because people can more earlier on in a cycle of violence can disclose what's going on to their supervisor and take time off to go to therapy or get medical treatment or get a protective order, change the locks, move out, whatever they need to do. It reduces risk in the workplace as well as reduce risk of violence. So it's one of those great prevention tactics. And so that's part of creating a culture within Metro in which we really wrap around survivors. We remove some of the stigma because especially as you think about a lot of the helping professions, we are used to seeing people as other, right? We all know that. We work ourselves to death and we're serving this other population. The reality is that we often need a lot of that support as well. So based on that, Lexington did adopt the same ordinance in their city. So it's already moved there. And U of L Health has not yet made it paid leave. So they're not a gold standard. They're maybe the bronze. But they developed a leave for their staff, which is significant. As you know, nurses and doctors might not be able to take leave unless they're allowed to. What they have done really interestingly is that their staff can go to their SANE clinic, their sexual assault nurse examiner clinic, and actually get seen. So if you were assaulted by your partner at night and you're a nurse and you're coming in for a shift, you could go in and be seen and get that forensic documentation of your injury as a staff member. So they're doing really innovative work. I say that just to say that in every context, we can be lifting the status of women and reducing harm that's happening. But that's just a medical example that I wanted to share for you all. If you can go forward, Catalina, to how do we make cities safer, more usable, more welcoming for women? So one of the areas that I think is very innovative and exciting, again, by way of explanation, I worked for 25 years as a lawyer in gender-based violence. I've written helped write legislation. Defer to the unofficial thing is oftentimes, the people who write it are the legislators, but some of us help in some of the drafting. But I've worked on legislation. I've worked nationally. I've trained nationally. I've done really high level work. Worked with Andy Beshear, then Attorney General, on ending Kentucky's rape kit backlog, brought millions of dollars to the state to make changes systemically, and still haven't seen the needle move on rape prosecutions, on perceptions of safety, and on victim well-being. I'm not saying that work was in vain, but it's a lesson to say we have to think differently about how we address violence against women. I think you can look at any news story that you look at and still see we have a lot of space to grow. So one of the innovative approaches that our office is looking at is how you can design cities and public space, such as LouMed Campus, the LouMed Commons. I'm pointing, I think, roughly that direction, to create spaces that are safer for people to come out in public space and be together and prevent violence against women from happening in the first place. So what might that look like? If you're a victim of domestic violence and you're isolated in your home and you're an immigrant woman and you don't know anyone in the city, but there's a nice public park that has a toddler story time that takes place outside once a week, and you start going and you meet a few people and you're experiencing domestic violence and suddenly you meet another woman, another mom, and you break that isolation. That's an example of prevention. Or if you are a nurse working third shift and you're working from a parking garage across what used to be kind of whenever LouMed Commons was not LouMed Commons, and was kind of that shady place of walking through it. I see all the women nodding in the room here. We all know what that feels like. Now it's well lit. How does that feel? Are we decreasing it? We've done some work internally with public health, with other folks looking at data of where sexual assaults occurred in the city and lighting to see if there's a correlation. We're starting to explore that. We have found there's a correlation, so there's a deeper dive into that. But that's an example of how you can design the built environment to actually prevent things from happening in the first place. And so I'm just going to quickly end with a few of those examples. Petalina, if you want to go to the next one. So I will say by way of explanation that we are part of an international network of cities called the City Hub and Network for Gender Equity, or CHANGE. It's now 18 cities. Manchester, England has just been added, but they're all bigger cities mostly than Louisville. But we were invited to join because of our ambassador program and because of the paid leave policy. They thought those were really best practices. The idea of this city-to-city network is that we share strategies across cities because women around the world face a large burden of unpaid labor that is less and less supported over time as we see eroding childcare system, eroding public benefits, eroding support, rates of violence against women, as well as just a lack of city responses to really collect the data and measure how we do for women. So one of the strategies, again, is urban design. And in about a year and a half ago, a team from London came to do research and participatory work here in our city to look at how the city could be made safer. So we've been doing things like night walks. We did a night walk in downtown last night to sort of measure how people feel in public space. It was women and men, and to look at design elements. We've done night picnics. We did one in Albert O. Jones Park. We have done engagement with girls in parks with Parks Alliance, which is redesigning. Because the research on parks is that girls stop using parks as much at age 8. Any ideas why girls stop doing it? Some of it is they start to be noticed and maybe looked at, right? So even though 8 seems really young, you start to really feel subject to the male gaze. But then parks are really designed around sports. And so there may be a basketball court. And girls might want to hang out. They may want to play basketball too, but when boys come in, they're the real ones taking up space. So boys end up taking up more space on parks and using it. Obviously, that has health ramifications for girls. It has all sorts of dynamics. So design for girls in parks looks a little different. It looks like engaging them in the process. So we did that with a group of diverse girls in a park that's being redesigned near Churchill Downs called G.G. Moore Park. Georgia G. Moore Park, Black suffragette and poet. Not a lot of people know her story. So again, that tie-in with women's history, and that tie-in that women can see themselves and girls reflected in a city really do contribute to that sense of belonging. And I will say at the end, I'm a lawyer. I can talk the hard facts and the laws and the evidence, but the more that I do this work, the more that I realize that I think the 2 strongest programs so far for the Office for Women are this work on design and the ambassadors because of that second word, belonging. So I think we have a crisis in belonging in our country right now. It is a deep need. It is deeply connected to people's well-being and their flourishing, whether they feel a sense of belonging. And one good thing of AI, when I surveyed the impact reports I did impact surveys of ambassadors this year, number one theme that came up was a sense of belonging. So I can check off boxes saying they felt increased leadership, they knew more about government, they felt more trust in government, but the highest sense was belonging. And that's what we're striving for as well in this sort of a safe city. So that may feel like a cushy term, but I think it's really, really worth looking at. So I would offer to you all as a strategy in any work that you're doing to really think about engaging networks of women. The Ambassador Network has been incredibly powerful. And I have this team of now almost 100 women and gender diverse folks in the city who want to step up and serve on boards, on projects, and focus groups, as community liaisons, could provide a wealth of input because I've already stepped up to want to be civically engaged. And then thinking about the work that you are doing, are there any tweaks you could make to bring perspective of diverse women? So if you're more interested in this work, if I've whet your appetite, please do follow the Office for Women. There is a newsletter. I'm on Instagram. There's lots of events. And there's much more that I do. I also, will do more training on any of these subject areas and can consult as well. But I just wanted to give you a deeper dive into those 2 programs today. So thank you.
Thank you very much, Ms. Hunt. Are there any questions or comments to her presentation?
I have a question. So you mentioned that with all the programs we've been doing, we've had challenges in moving the needle. I know we're time limited, but assuming we were in an environment where we weren't resource constrained, what would move the needle?
Oh, I love that question. So as we could solve a lot of the issues right now if we supported families from 0 to 3, right? I mean, we all know that research that I think that, the ACE research, the adverse childhood experiences, understanding the live reality of a lot of folks, that if you were supporting moms and dads, if we were engaging, the research on fathers, on engaging fathers early on, men as caregivers is really promising. I would point you to a group called Equimundo, which did a report called The State of American Men in 2025. They talk about a lot of the issues happening right now, the polarization, the kind of targeting of young men. But the one promising area is supporting caregiver initiatives is not only supported by men, like across lines of belief, but it has all these benefits. So I would say really an investment supporting families, 0 to 3, all families, regardless of class. Universal basic income for women. There's been some promising pilots looking at survivors of domestic violence. The 3 calls I get to my office from constituents, number 1 is for housing. Number 2 is for domestic violence services. And number 3 is just for cash assistance. So to me, people are telling us what they need. So that would be the money. But I really think money is not the only solution. It really is a mindset shift to open up the possibility to share power with community more. The ambassadors has taught me that. So I think money is part of it, but we don't need to get stuck. We are a very wealthy nation. We're wealthy in terms of money and people resources. And I think there's a lot to do. And the Office for Women is proof of that. I mean, I have a $45,000 budget a year and 1 staff. And we've been able to do great impact. So I think leveraging people is really part of what we're the opportunity that's out there. So I'm trying to spin the current challenges. It's housing is really hard, right? I mean, if we could move the needle on housing, but I think some of those other levers we can move.
Thank you. Thank you, Dr. Goldberg. Anybody else?
Catalina, is there a question in the chat?
Oh, okay.
Any other comment or question? Dr. Eccles?
I just want to say that I think that the work that you do is very impactful, just giving it voice. And especially in our city, a geographically kind of outspread city where we have a lot of, I think particularly young girls that are coming into, their adulthood, having to travel, work, things that you're speaking about, like the safety of the streets and the travel ability. So I think that those are just important things. And again, if we get to these girls younger and teach them, I don't know, all the women in the room, I'm sure have heard that, you're walking to your car alone at night, you keep your keys in your hand. You have to be very situationally aware and very, cognizant and mindful of your surroundings. And I have very young girls that don't go anywhere by themselves, but these are things that as a mother and somebody who lives in Louisville that you're thinking of all the time, and even things that you're passing on. So I think it's important when we come to rooms like this and spaces like this that we're giving it voice. And as a one-woman office, I commend you and I appreciate you. I just want to say that for being here and sharing all of this information with us. It's really important.
Thank you for lifting that up. If I could have one more thing about data that's really interesting. So the data folks mapped the addresses of where I have applicants for Office for Women Ambassadors. So last year I had 162 applicants for about 30 spots. And the data people said, Gretchen, this is so exciting because we always joke that we do one map for the city. One map on health disparities, poverty, gun violence. Certain areas pop up red, right? A lot in West End, some in the South End. They said this is the first time the map lit up, the same map, but for a positive reason. These were all women saying we're leaders, we want to be engaged. So there's something really profound about people who are closest to the need right now. We hear this, who have the solutions. And I think, talking about youth in particular, they have ideas. They have really great solutions of how to change space to be better for us. And I do a lot of engagement. I'll do shadow days with teens at my office too. So if you have young people in your life who want to be exposed to this, they definitely can do work here. So thank you for that.
Thank you. Dr. Anderson?
Gretchen, number one, is there an age recommendation for these ambassadors? And number two, how would you afford or publicizing it? I'm totally unaware.
Yeah. So it's the fall. I do one cohort a year. They apply in September. This starts in January to June. You do have to be 18 for that, and that's the experience that we found works best. And then the connection is open. I do think there are other programs in Metro that we collaborate with. The not community health centers, the community centers in the parks have what's called Girls Collective and do really great programming with youth. So we try to partner with them for younger kids, as well as the YMCA, which has teen dating violence prevention. So we partner with them on those programs.
So how would somebody go about signing up for
So-
getting
yeah, they-
information or-
So following either on social media or signing up for our newsletter is the easiest because I try to distribute it widely. So if you all are on social media, I would say start following it and share it. Yeah.
Thank you.
Thank you so much. Anybody else? Anybody else virtually? If not, we truly appreciate you sharing your enormous work as a one-person office, doing all these opportunities for women to speak up, to connect, and to belong. Thank you so much. Appreciate it. Thank you. And now we pass to, we will continue our agenda and allow time and space for updates and reports. For the mayor's office update, now I yield the floor to Deputy Mayor Nicole George. Deputy Mayor.
Thank you, Chair, and thank you. I think getting to hear about the work of the Office of Women and how it integrates into all the other work, particularly public health, is motivating. I'm sitting here thinking about what happens to the other 167, did you say, applicants who apply, and how can we engage those women?
We go to Connection. So that's what I started Connection, which is this Friday. It's a one day. But yes, we need more places.
Okay, yes, because limited spots always, and how do we engage others? So just really quickly, and as a reminder, most folks know a lot of the time in the mayor's office is spent right now on the legislative session. I believe today's 38 of 60, and I saw something the other day that, over 1,000 bills have been filed. So it's a lot to keep up with. I want to give a big shout out to public health. I know you guys have been providing a lot of information on analysis, which is really important. And I'm hearing a lot of concerns and questions in the community about Medicaid, quite frankly. I was at Cafe Louis on Saturday, and of course that came up as a big issue. So thanks for your input there, and hopefully we'll know more after the filing deadline, which is when, I don't know, coming up, right? This is the last week to file.
Yeah, this
Yes.
is it.
So work on that. And the second thing is obviously we're underway with our local budget process, the planning process. So again, a lot of work that public health has been doing there. But certainly this is a good time to be getting connected. This is really the place where the mayor's budget is formed. And so it's gonna look a little different this year. And there are gonna be some difficult decisions made, as there is every year, but definitely be paying attention to that, and I look forward to sharing more at next month's meeting.
Thank you very much, Deputy Mayor George, for that update. Now we go to the director's update. I now yield the floor to Louisville Metropolitan Health and Wellness Chief Health Strategist, Connie Mendel.
Thank you. So everyone received the director's report earlier in your email
Yes.
from Orlana. So just to highlight a couple of things, as our chair mentioned, our respiratory viruses are still circulating. Our dashboards and data from the hospital show that. And anecdotally, I'm sure we all know of friends and family that have the flu or other. It seems those things keep popping up. Our infectious disease program is working with schools and other congregate settings just to try to isolate and identify and keep them safe. So I know in other counties and in the states, some of the school systems have closed for a couple of days to try to recover from those. So, our message is the same. We always recommend the immunizations for flu, COVID, RSV, for older adults or the very young, or those that have some compromised systems, and just do those things that we did, during the COVID pandemic. As we washed our hands frequently, stay home anytime you're not feeling well, so we don't share that with our schoolmates and workers. wear a mask as you're recovering, or and try to stay away from those that are not feeling well. So we can't share those things enough. There's also, I think, some very interesting information in the report about our smoking and vaping program. We have launched our underage buying program, where we have folks between the ages of 18 and 20 go out and undercover buy. We have detected establishments that do sell to underage folks, whether that's tobacco products or vaping, e-cig products. And we encourage anyone, if you're aware or suspect of establishments that are selling to those under 21, please report that through 311. And there's some data there in the report. And then lastly, I'll talk quickly about the hepatitis C work that we're doing here. We have been able to obtain some instrumentation, so we can do through a finger stick a confirmatory hepatitis C for our clients. And so hepatitis C is a concern in the community. Louisville sees 2,000 new cases a year, which is obviously concerning. And I'll talk a little bit more about that in a minute. But with this new equipment and the clients that we work with, we do that finger stick, we can confirm that and then readily connect them to services and treatment. So, because many people who have Hep C, they don't know. They're unsymptomatic for many years, as our medical professionals know. So cannot say enough to encourage promoting testing and treatment of hepatitis C. So that is all that part. Did you want to go into the strategic plan at this, or is that later?
Later.
Okay.
Later, yes. Thank you so much, Chief Health Strategist Connie Mendel. And we go to family health centers. I'm gonna yield the floor to Dr. Bart Irwin, that is accompanied today by the new elected CEO, Mr. Sam Riddick. I yield the floor to you.
Thank you very much. I'll be doing both my report and Ashley's report. I have a slide that I had sent down. It was a chart, if that could be pulled up.
Oh, sorry. Okay.
So Ashley is the chair of the Medicaid Coalition meeting. I think it meets every other month. And at their most recent meeting on the 9th of February, they talked about the growing number of children losing Medicaid coverage. So I'll stop for a moment with her report and show you this graph. The blue line is, and this is for Jefferson County alone, but is echoed by what's happening in the state. At the end of the public health emergency, April 23, recertification for adults began across the state, Medicaid recertification. So you see that at the height, there were 184,000 Medicaid recipients in Jefferson County. That has been greatly reduced over the period of the last few years to 131,988. So there's a precipitous drop in the number of adults that have Medicaid. And it's a 28% drop. 51,000 people, adults, no longer have Medicaid. Some of those have moved on to do the exchange, buying insurance. Others may have gotten employer-sponsored health care. Many have become uninsured. Then in the orange line at the bottom, these are children. And recertification for children did not begin until June of 25. So you see there's this pretty steady line until just recently. And my little data there about the drop in county child Medicaid recipients is not updated. The number there was 837, and that was from April to August of 25. But now that it has decreased by 4,645 children. So you can see there's a rapid increase of the number of children losing Medicaid. So why are they losing Medicaid? It's not that they're ineligible. Probably the largest factor is that the parents or guardians were unaware that they needed to be recertified.
Yeah.
Or they're not submitting the right documentation or something like that, not that they're not eligible. So the committee discussed how they could reach out to and educate families about childhood renewal. Other items. We are closely watching House Bill 2 that is moving through the House and has picked up speed. Our concern about this bill is that the Medicaid work requirements, Kentucky Voices for Health is asking that Kentucky's Medicaid work requirements are no more stringent than the federal requirements. At this time, the bill does pose more stringent requirements especially reporting requirements by adults who are affected by this requirement to submit evidence that they're working or volunteering or other in-job training, that kind of thing. So Kentucky Voices for Health has a lot of information. If you want to access their website, they can tell you how to intervene. The next coalition meeting is scheduled for the 13th of April at 4 p.m. And that concludes my report.
Thank you very much, Dr.
Dr. Irwin, I have a quick question. Your source data for this, where did that come from? If I cite your beautiful graph here.
Okay, thank you, Scott. That data comes from the Kentucky state website. If you put in your search engine, Kentucky Medicaid recipients by county, you'll pull up that website. The state has been a little slower in producing childhood data since the recertification began. So my graph goes until January, but they're missing a couple of data points for the subsequent months.
Thank you.
Question, sorry.
Go ahead, Dr.
Do you
Goldberg.
have data of the 50,000 plus people who've lost their Medicaid? Do you have any data, how many have moved into the uninsured category? Can
We
tell?
do not. The only data we have is that I can tell you what's been interesting in the past few years is that the number of persons who have commercial insurance at family health centers has increased pretty dramatically. I think we're up to about, 13% of all of our patients, which is over 10,000. And we have seen a steady uninsured rate until recently, and that's starting to tick up a bit. So we're assuming that part of these folks who are losing their insurance are becoming uninsured.
Thank you very much, Deputy Mayor.
So first of all, I found this very concerning, obviously, in terms of the reduction. So what is the ask? Like, how can agencies help support? I know we have connectors. I know those connectors, where do we see in terms of these 4,600 children? What does that demographic look like? Where are they in our community? And what is the request in terms of how community can, I'm assuming if most of this is just, as you said, lack of knowledge to recertify, how can we help get that word out?
Yeah, I did not attend the coalition meeting, so I don't know what ideas they had there. But we certainly, at family health centers, 25% of our patients are children. That's about 10,000 children a year. We are being assertive and letting folks know and engaging them, hopefully at our front desk. If you've lost Medicaid, let us know. We also look at our insurance. If they've had insurance last time and they don't this time, we encourage them to see our connectors. Community-wide, I think, I don't know what the solution is for outreach.
So anyone can attend this Medicaid coalition meeting?
Yes,
Okay.
I believe it's held at the health department, right? Or is it virtual at this time?
I don't know. I
I'll
think it's virtual.
put that information in my submission for the minutes.
Okay.
Thank you. And I think the kids can be recertified throughout the year. There is not a date. So I think the most important role we can play as a community leaders is to remind our communities that this is important, to pay attention. And if they don't know how to do it, they can always reach out to Kentucky, the Kinect individuals, or even if they are patients at Family Health Center, to reach out to ask for guidance would be the easiest way to do it. It's reassuring to know that there's an increase on private insurance, so that would reduce the concern, but still the numbers are really, really worrisome.
All right, I'm sorry.
So please, go ahead.
Go ahead, Dr. Hill.
Well, I was gonna say, this is the next piece of information that would be really helpful is, if you look at the individuals that are falling off the Medicaid ranks, where are they going? I share Family Health Center's hypothesis, Because in 7 counties, we see an increase in uninsured as well. So our hypothesis is that there's not an insignificant portion of those that are ending up underinsured. But I haven't seen data that supports that this pool of individuals that are coming off are where they're going. And that would be a really interesting question for us to wrestle with as a public health question. We also see an increase in private insurance or other insurance as well. So as Medicaid drops, those other two are increasing. So I think
So you've seen that trend in 7 counties?
Thank you.
Yeah.
Do you know if there's any legal mechanism, I'm sorry to take up committee time, is there any legal mechanism for the cabinet notifying connectors or another agency that people are in danger of losing their Medicaid certification?
I don't think that takes place. There are things the state can do, like look at other information, like food stamps, and use that data to reinstate. And I think they do as much as possible to say, yes, you're still qualified regardless you didn't respond to our letter.
It'd be helpful to have hard data to back up what I think we all see going on, which is the significant number of people moving in the right direction, but also a lot of people losing their Medicaid for nothing other than a paperwork issue. And there's solutions around that. But when you look at the ripple effect of losing the Medicaid and the economic impact and the human impact from that, if we can find a way to have that mechanism in place, you get a lot of bang for your buck.
Yeah, I don't know if the state collects that data or tracks people, probably not, but I'll ask.
Thank
Well, it
you.
almost seems like if you apply for one benefit, you should be nudged, so to speak, or the default should be that your other benefits trigger, but that would
I think
be,
you are.
you are.
Generally, yes, especially like for children. So like if it's a
Okay.
family that has applied for food stamps or applied for like housing assistance, that kind of all that packet, or I don't know what the process is, but that kind of all usually is bundled together.
I think there was a recertification. If you're new to Medicaid, I don't know that automatically you receive it
Yeah.
based on like for other benefits.
It doesn't happen automatically. Yeah.
Trigger letting you know you're available for these other programs as well.
Dr. Shah, you have a question?
Yeah, question and a comment. The comment is that, at hospital level, there is, hospitals required to collect social determinants of health. So that might be another data pool that folks can look into to say, hey, can we use that data to say who's at risk or who should be eligible for Medicaid from that standpoint? And then the second one is there a way where, like when folks are accessing care, at that point, we're catching them because that's when they're probably thinking about it and saying, hey, my Medicaid is expiring or it's coming up, maybe getting them into the system, signing up at that moment. I don't know if that's happening today, but that might be another way of preventing folks from falling off or missing their paperwork.
Right. I think U of L Health, the hospital, and family health centers and other health centers, community health centers do try to catch people at that time of their visit if they notice they're uninsured.
Thank you, Dr. Irwin. Thank you, Dr. Shah. Dr. Eccles?
Just to speak to that, I don't know, and not to add like another thing to what JCPS already does, but I wonder if, because we have the nurses in the school, I know they don't usually have access maybe to whether or not the kids are insured, but if we even had like flyers or just like something that could go out that can go home with the kids, I don't know if that would maybe be,
A reminder.
yeah, just
Reminder.
look into this if they're not, regularly seeing a pediatrician or something like that.
I don't know if Eva Stone's here today, but she
She
can
will.
certainly provide some information.
Dr. Stone, are you in?
I don't know if Eva Stone is here, but this is Michelle Neal. I'm one of the nurse practitioners at JCPS. Nurses, we are our nurses in our school. They try to ask the students and the families if they have insurance, mostly for vaccine purposes because we have several vaccine clinics throughout the year. But our nurse practitioners, we have access to the website to look up students to see if their Medicaid numbers are active or not. And so we do try to be aware that we see a lot of students who are uninsured and who previously had Medicaid but have lost their Medicaid. And we are actively now educating our nurses about how to connect families with how to apply for Medicaid. We are connected with some of the neighborhood places. I know we have a clinic in there. So they've been also really helpful with helping us kind of navigate those families who have questions about Medicaid and who want to apply.
Thank you, Ms. Neal. Do you have any updates from JCPS Health?
I do not. I'm not sure if Emily Reese is on here. She usually keeps all of our data, but I think she's out sick for the day.
Thank you very much. Appreciate it. Okay, for Greater Medical, Greater Louisville Medical Society, I yield the floor to Dr. Goldberg.
No action items to report.
Thank you very much. The Kentucky Nurses Association has had a change in the leadership recently, so I'm introducing to the board Ms. Joan Great. She is the new Kentucky Nurses Association president. Ms. Wright, do you have any updates or action items to share with the board?
I do not. Thank you so much for inviting me. I really appreciate it. I don't have any updates at the present time, but next month I'll definitely have additional updates.
Thank you very much.
Thank you.
Is there any old business?
We have the resolution.
Yes.
Okay.
So at the last meeting, Louisville Metro Public Health and Wellness submitted a request for our review, for the board review to consider them and approve the local fee rate increase. Do you have anything else to add to that?
Sure. Just wanted to add quickly. So our public facilities team, they're the ones that are charged with doing pool inspections. And what this permit fee covers is, well, we hope for it to cover most of the costs around the sampling program. So we hire seasonal employees. We have about 500 pools in the Louisville area that we inspect. So those include those that you would see at health clubs and spas and Ys and hotels and apartment condo associations. So basically anything more than a backyard family residential pool. So the program right now, we've not increased the fees since 2007. And so we're running at about a $65,000 deficit. So the resolution is to increase for year-round pools, indoor pools, from $200 to $300, and then for outdoor or your seasonal pools from $75 to $125. If you look at inflation rates, that $200 in 2007 equates to $320 today. 75 equates to 100 today. So the one is still under, the inflation rate, and the other is pretty close. So.
Are there any questions or discussions regarding this proposal? And if not, may I have a motion to approve the local fee rate increase for indoor pools by $100 from $200 to $300, and outdoor by $50 from $75 to $125, as proposed at the last meeting by Louisville Metro Public Health and Wellness. May I have a motion? Dr. Eccles, may I have a second?
Second.
Thank you, Dr. Shah. All in favor, please raise your hand. Aye.
Aye.
Thank you, Dr. Shah. Thank you. Any abstentions? If not, the motion is approved to increase the local fee rate as proposed by Louisville Metro Public Health and Wellness. Thank you very much.
Thank you.
Thank you so much for your presence today. And it's very important to brainstorm the Board of Health contribution and the support of the new Louisville Metro Public Health and Wellness strategic plan. Louisville Metro Health and Wellness has two priority health-related, four priority health-related issues. The first one is reduction of hepatitis C. The second one is the increase of childhood immunizations. The third one is support of the reduction of lead-elevated blood levels for children. And the fourth one is reduction of underage tobacco sales and enforcement of the tobacco license. So do you want to guide us, please?
Sure. So I'm passing around now a copy of the high level on our strategic plan. I also sent those out by email to those people that are joining us online. So this is our strategic plan, and it says 2025, and we did begin this late last year. So we were officially in 25. So really, our overarching goal is healthier communities. That's always our goal. You know, for our residents in Louisville to reach their highest potential health and wellness. So in doing that, we need your help. We need the community's help. You know, we can't do this alone as a health department. So our focus areas, Adeline, if you could go to priority areas. Okay. So a lot of those are around maternal and child health. We need to do a better job with our infants and parents. So our goals around maternal child health are those reducing rates of preterm and low weight births. And we have data for all of these things. I'm happy to share with you. And reducing the rates of congenital syphilis. And I feel like we've reverted back to 1970s public health when we talk about syphilis. But Louisville has been 12 years of increasing rates of syphilis. And we are having infants born with congenital syphilis. I think the case count for 2025 is around 28 cases, which is 28 too many. Easily treated condition. And then also looking at our immunization rates, we've talked about that previously. There's been a lot of discussion when you look at the sheer number of measles outbreaks around the community. I know Dr. Stone reported on immunization rates at our last meeting. So those are things we definitely have got to get those increased. And then also lead poisoning. Again, it's 1970s public health. We still have lead poisoned children in our community. No level of lead is safe. There are approximately 400 children that the health department currently now is doing casework with, following them medically, obtaining treatment when the levels are very high, and then also from an environmental standpoint when we're in their homes and trying to detect those hazards. And then our other area, as I mentioned earlier again, is our hepatitis C areas. Kentucky ranks third in the country, third worst for hepatitis C rates. So with this strategic plan, it was time for us to put out a new strategic plan. We're very intentional on these focus areas. Now, we'll still continue doing all of the other work that we continue to do, whether that's inspections and enforcement, with our TB clinic and other sexually transmitted illnesses and immunizations. And so, but in addition to those areas, these are our focus areas. And when we look at, you can go ahead, next slide. So, and this just some of the basic data, you know, when we look at our poor birth outcomes, preterm birth rates, 11%. A lot of that concerning is timely prenatal care. There's a large percentage of our population that do not receive first trimester care. They don't receive any prenatal care in the first trimester. There's some within our population that don't receive that until the third trimester. Yeah. So concerning. So we're working on this internally with our different organizations and partners, but this is really a call to the board in looking at some of this data and these program areas of where you see yourself, where you can help us advocate, engage, bring the community together. Go ahead, Kathleen. Congenital syphilis, like I mentioned again, 12 years running of increased cases, easily treatable. So where are we missing, again, prenatal care? Where are we missing opportunities to diagnose and then treat and then prevent congenital syphilis? So we know that means bringing down the syphilis rates in our general population, but particularly for our pregnant population. Go ahead. Yeah, and we've talked about immunization gaps. Yeah, the data is It's hard to collect because it's not mandatory to report immunization data into the state system. Some electronic health record systems do automatically report that. Some do not. So there's certainly some interoperability issues. But again, you know, and we are working to expand our mobile immunizations. We are obtaining, one of our actions, we're obtaining a mobile vehicle that has all of the medical grade refrigerators and freezers. So we can take that out more into the community. But, you know, how can we expand our collaboration with our school system? And again, you know, start with healthier children and prevent those vaccine preventable diseases. Yes.
Just a brainstorming question for me, really. So I'm speaking a little bit out of my swim lane on this, so there's some of you that have more experience in infectious disease can help correct me. I know at 7 counties, we are particularly interested in trying to collaborate in early detection for STIs. And we do a fair amount of point of care testing, but syphilis is not a point of care test. It's a serum test, I believe, right? It's a blood test. And that creates an obstacle in being able to get that done in a timely fashion. I would love to brainstorm with ways that either we can make that more approachable, because I think early detection is a key answer. Just like with many of the others, we're detecting in the office, giving a response in the office, and we provide that, particularly in our addictions. This is a high population, our addictions and our populations with severe and persistent mental illness. We see these run fairly quick, high, and point of care testing allows us to early identify and intervene. Syphilis is a problem.
Yeah.
And I'm open to suggestions about better ways of doing that kind of early intervention and testing if anybody has any brilliant ideas.
So we are fortunate to have our own laboratory, the building that is right next door. So I think that's a great idea. Let's see how we can work together. And if nothing else, offer those services through our laboratory for it wouldn't be point of care.
Right, that's where, I mean, you guys are already great for that. So if we send somebody over, no problem.
Yeah.
If we collect a sample, no problem. You already do that. But just thinking out loud, because moving from point of care to a venipuncture, already people have a different perspective on things. And now waiting for a result, sometimes we lose people to follow up. And I really want to be able to give responses at the time. And those are two issues that just are a struggle. And it doesn't sound like anybody else has got any brilliant, I mean, you're facing the same issue.
I know.
I'm looking at Bart to see whether or not, yeah, Bart, tell me how you,
Just solve that.
yeah.
So we do have Stacy's Ingram, who is the director of our health services, is on the call. So let me, let's work with her and see.
If she could get a CLIA Wave point of care test for syphilis on the market, that would be awesome.
I will just say though, on that area, this is why our primary focus in this phase, and Stacy can jump in, but the data, really knowing where the issue, if there's a concentration, because like you said, it's already so difficult that if we can have some more data on maybe where specific populations at highest rates or something like that, I think that's where we are too. And my team is also working on this, but we don't have the data that we need to even really say this is where we can start thinking about this.
Well, my speculation is particularly in our addictions population is you have individuals that are exchanging sex for drugs. And so I'm just a dumb psychiatrist, but the more partners you have, the increased chances you have exposure, the increased spread rate you're going to have for lots of different diseases. And so trying to figure out how do we do the early intervention. And we've done a pretty good job with things like committee and trick and things like that. We can identify those right at the time of the evaluation and recommend treatment. And most people take treatment if they know at that particular point. Syphilis is the one that we're really trying to figure out how do we solve.
Dr.
We have,
Bryant?
we have a question.
Yeah, our
Dr.
medical
Bryant?
director is on the call. Would you like to share?
Good morning, everybody. This is Chris Bryant. There actually is a point of care test available for syphilis that is CLIA waived. I don't think that we have implemented in any of our spaces, and I don't know all of the challenges with implementing it. But that is something that we can collect information about offline and share.
Be great.
Thank you so much. So this, we are developing connections, and this is what we needed to start at least working on one of these topics. And thank you, Dr. Ryan, for your contribution. And we should have invited you earlier. I'm sorry for the delay. And we're gonna let Connie to continue so we can keep on brainstorming on the ways that we as community members can support the job. Go ahead.
So, as I mentioned, we're expanding our mobile immunizations. But we can't do it alone for a community as large as we have. We're really focusing in on childhood immunizations, but also we also provide adult immunizations. So both of those. So our hope is from this brief introduction of our strategic plan that maybe we can put some committees together, bring in, additional partners and determine what is the best way that we can move the needle on these specific issues. Go ahead, Catalina.
I think the Immunizations Advocacy Committee also wants to participate. They are part of the community advisors, but they are really, eager to do something. So we may bring them also to work with immunization increase rates. So, okay.
Yeah, and this is, I talked a little bit about lead poisoning, but again, lead poisoning can lead to irreversible cognitive effects, with long-term outcomes. We have way too many children in our community that have lead tested in their blood. And, we look at our hot spots, our Northwest and West core is 9 times more likely, and that based on the age of housing, but also the condition of the old housing with the lead paint and lead contaminated soils. So in part of that, we had piloted prenatal lead testing with family health centers that has worked well. We have identified several pregnant people with blood lead levels and then subsequently either newborns, in which identified as a newborn is much sooner. The earliest that we would typically see with children be tested at 6 or 9 months. So, getting that identified much earlier in treatment. So we're looking to expand that prenatal lead testing. So there's an opportunity there as an example. Go ahead, Catalina. And then we've already talked some about hepatitis C though. So that was is that one of the tests that you all do now? Do you all do any?
Yes, and since we do very small amount of primary care,
Great.
a large chunk of that is related to hepatitis C. And we have a connection with U of L's hepatology and again, identifying that particular patient demographic. So.
Yes. Yeah. So, it's certainly concerning. I said with 2,000 new cases a year, or 2,000 new people are diagnosed every year in Louisville with Hep C. So, and we, as we know, it can go on for a long time before people start feeling those adverse effects. So the earlier that we can identify, we have expanded testing within our harm reduction program sites. There was a little note in today's director's report that talked about the instrumentation that we're excited to bring on. And so work to be done.
Another question, sorry, I'm talking to.
Please, go ahead.
No.
I'm particularly interested in the lead abatement. We had a very compelling presentation a few months ago that just has left an impact on me just in terms of the distribution across our counties. And this is just sort of an open question because I just don't know that much about it. My recollection is that the ultimate solution was along sort of 2 different lines. Either one line is that there is a significant amount of government spending, whether that's at a federal level, state level, city level, spending for abatement, or the navigation through making commercial property more readily accessible in the area, because when they develop, they have to abate the property in that process. That's my recollection from that. So are we, as a Board of Health or a health department, thinking beyond just the testing, and how do we advocate for ultimately the abatement of the environment where, because that seems in the long run the direction we should be thinking.
Yeah, our goal really is to try to ensure all of Louisville's rental housing is determined to be lead-free, or at least lead-safe. You can safely encapsulate lead, the old lead paint on homes, whether that's with siding on the exterior, or just ensure that the indoors, there's no chipping, peeling, crackling, and you can encapsulate that old lead paint. So we do work very closely with codes and regulations. So as they go out and do regular inspections, they're also doing a quick test for lead. If they detect lead, then that property owner is required to have a more extensive lead test done to determine where all of those hazards are, and then work with our lead team here to develop a plan to remediate that lead. And then we have a new lead-safe rental property. So, we have a lot of work ahead of us, but, we are currently working with hundreds of properties. Again, it's a close relationship with code enforcement. So that's one of our steps, is try to get ahead of it because right now, it's children being referred to us. They already have lead in their blood. So by working with code enforcement and we also, folks can reach out to us if they have lead, if they suspect lead in the home, then we'll do testing that way. But, working with code enforcement and getting the rental properties tested, we want to detect the lead and get it fixed before children move into the home, or their grandparents move into their home, or caregivers.
Dr. Burns has a question.
Dr. Ryan, do you have another question?
Dr. Burns.
Dr. Burns? There is a point of care testing, however, many patients are already positive. That is, if they have antibodies and once a person is positive, they will always test positive. In which case we need to check the rapid plasma regime, the RPR, to tell if a person is acutely infected or not. So
He's talking about syphilis, right?
he's talking about syphilis. If they have been positive already once with the test, they are gonna test positive. So we will have to differentiate with a plasma test, just like the drawing of blood, just like you were saying. Thank you, Dr. Burns.
The point of care is intended as a screening test. So you're never going to be, oh, you're positive, here's a penicillin shot.
But that's a good way to identify somebody that is positive, and the next step would be. But there's an interesting suggestion that Ms. Hunt just had. What about those that have been identified as positive are incentivized somehow to do the follow-up? We get the blood and come back, for the next thing. I don't know.
I would love to pay people to get screened. That would be great.
Well, I had wondered about incentives. I didn't want to say it because I didn't know there was like an ethical issue around it, but
No,
I was wondering about like TARG tickets or meals or something as an incentive for.
I mean, there are wellness incentives. I get an incentive for taking my flu shot. I mean, I think it's been proven that it's.
Right now.
Particularly if we pair it with something we're already doing. That's why I mentioned like for Office of Social Services, TARG tickets,
There's a lot of low hanging fruit, and again, I don't want to take up everybody's time, but if you follow the concept, make the right thing to do, the easy thing to do, there's a lot of opportunity for improvement in terms of lowering barriers as opposed to providing incentives. Because if you provide a TARG ticket, but then you have to jump over all of these hurdles to go get your TARG ticket, that's not really helpful. If you take away most of those hurdles, which again, lots of opportunity, I think you would really move the needle on this. If you look at the experience of other countries where, if you live in the UK, where everything's just covered under NHS, you can get a test kit in the mail. Testing for syphilis is just a finger prick. There's good validation for doing self-swabs, highly effective. If you're positive, you get your drugs free in the mail. There's lots of examples in other health systems in pretty much every industrialized country. I'll get off my soapbox. There's great models for us to follow if we really want to move the needle on these issues.
And we definitely do. I see Dr. Bryant.
Dr. O'Brien, please.
Thank you. I completely agree with Dr. Burns that this is the point of care as an antibody test. And so if it's positive, the patient will need to be referred for another test to sort out whether or not they have active infection. But recall, we're routinely using antibody tests for hepatitis C in a variety of settings, including harm reduction. And it's not perfect. We've transitioned to PCR test in some settings, but I think there's value worth exploring, even with the limitations.
Definitely. We agree with you, Dr. Ryan. Anybody else? The next slide, please.
All right. So our goal is healthier communities. And that means eliminating congenital syphilis. That's a bold goal. We know that. But we shouldn't have any infants born with syphilis in our community. We have the ability to treat. We have the ability to diagnose. It's now our 5-year plan, now down to 4. Increasing connection to treatment and treatment for those with hepatitis. Our goal is to increase that by 20%. Get our vaccination rates up to 90% for our kindergartners. We're reducing, obviously, exposure to lead. So, these are our goals. So what I'm asking the board is to look at these, look at the handouts, where you see yourself, where you see your connections, your energy, what is your heart and your head telling you that you can contribute to help us, facilitate these goals. Yes, me.
I love this idea, and I think just something to think about is ensuring that our speakers, when we're learning new things, align with these activities, having members of this board present on things they're doing to spark ideas for other agencies. I love that idea of being grounded. This is a tremendous plan. While these are big, you've given us big tasks, they're also doable in a lot of ways. And so look forward to learning about progress.
You've presented some great metrics here among these goals that, fully endorse these. Would it be possible to create a dashboard that we could hand out to the board every month?
Looking at me, because
Right.
it's, yes, so, having a public facing website is,
Yes.
it is going to have dashboard. It literally just cleared my, yes, we all do. It just cleared my hurdle. I had to review the first mock-up this week, which I finally did.
Toggling.
It's not fancy yet. It's like a preliminary, here's the info, but yes, that is in the works.
Green, yellow, red kind of progress. And
Yeah.
if you can get that to GLMS, I'll work to get that presented at our board meetings.
Thank you.
Great
Yeah.
idea. And another thing is, we already know, we're already thinking on ways to contribute, and 7 counties, Dr. Brian is going, and he has also, made us think about things, but we're already working with JCPS regarding immunizations, and we will continue doing that. So let's take a look at these healthier community goals and see, maybe exchange emails, through exchanging emails and seeing what can we do. Maybe we won't be able to reach all the goals, but maybe we can work on 1 or 2 and see how we can contribute with what we're doing. I know Dr. Randy is already working hard for, dental care for those uninsured. So little by little, the goal is to have healthier communities. Tony?
Yeah, and in light of March Madness, public health is a team sport. You know, we need the entire community in on this. We're going to do our very best. And I've challenged our team, really. I mean, this, I don't know if you consider them bold, but these are bold goals for our team. And when we first proposed those, some of our subject matter experts said, we can't do this. I'm like, no, it's not a collective health department. I mean, it has to be a community. So
So I just want to say, in tying that into, I think the role of influencers is another big thing. And I don't mean influencers like social media, but highlight women's sports, another value that the mayor's brought up of, and just seeing what Coach Bev Yanez did in talking about fertility after her 2 miscarriages. If you don't know, Coach Yanez is Coach of the Year for National Women's Soccer League. She coaches Racing Louisville. She suffered 2 miscarriages and was very public about it, and then went on to do a lot of work with fertility. And I think there's a few women in sports in this city who might be interested in championing, syphilis is a hard one, but like definitely maternal weight and maternal health. I just think,
I had syphilis and
about-
I got it treated.
but I see how that moved the needle on talking about initiatives. She's gotten so much feedback and raised awareness. So I just think about there may be a few people that you want to engage in visible ways on a campaign.
And there's another idea that comes to mind. What about presenting this strategic plan through Dr. Goldberg to Louisville, Greater Louisville Medical Society to see how many of those physicians working and the ones that are getting ready to retire or the ones that have retired, how many of those physicians we can involve and get into the planning. Dr. Goldberg?
Yeah, we do have a large core of retired physicians. We keep them active. There's a monthly speaker series every month, but one of the things we're looking at is how can we leverage that group to work in public health and covering emergencies and things like that. So again, the things that you're measuring and that are being publicized is what gets attention. So again,
Maybe having Connie to come to your meetings to engage people.
I mean, that would be great, happy to have a report, but also, if we're reporting this out every month, it brings it to top of mind and, sparks ideas about what we could be working on. And there's a throw off. I mean, you might want to say, are these the best metrics to follow? And it really doesn't matter because in the course of tackling syphilis, which again, the rate should be 0. The throw off from that is we're also going to, work on the sexually transmitted, infections and healthy behaviors and so forth. So these are just surrogate markers.
May I ask one more question about the data on the maternal health? Do you have that broken down more by, or seeing any trends on like age of the moms? I would just be curious to track that.
Going up?
Or the ages going down. So we're seeing rises in like teen dating violence. And
Yeah.
you think about like those coercive factors that are keeping people from getting care and all of that. I'm just curious about these larger trends we're seeing in violence against women and how that's impacting that.
Jennifer Bowman, our Chief of Staff, formerly Maternal Child Health Administrator.
I was just really happy that, because while you were saying it, everybody kept talking about congenital syphilis, which is really important. But I was like, can somebody take on preterm and low birth weight? Because that is something that we have not been able. So Healthy Start is a great program. It really helps educate and helps reduce some of these disparities. But preterm birth and low birth weight was one of those things that always kind of what you were talking about. We're doing all these things, but we're not moving the needle. And that includes in that program. We do a really great job in infant mortality, but preterm birth and low birth weight, that's one of the places that we struggle. So we're always looking for ideas of how to do that. And honestly, moms, taking care of mom is the key to that. And I feel like mom doesn't get enough attention. Babies get a lot of attention. So looking at ways that we can, so doulas are a really important part of that. But to your question about, we do track teen births. So they could give you some of that information.
Just what I will say, I mean, you all probably know that the number one cause of death for women in the year postpartum is intimate partner homicide. And, it's so correlated and all of that. And then collectively, what's happening with the status of women, that the pay gap is widening for 2 years in a row since the first time since the 1960s. People are losing housing. So I think all those systemic stress factors, I would anticipate that you're going to see worsening status of
maternal mortality, I think 91% of maternal deaths are preventable.
91%.
Something like that. It's very high.
It's.
So we got another thing to consider, changes that can be done through our activities as community members that may have a huge impact on these numbers. So I think we are gonna conclude our discussion. Please think about this. We will send an email requesting your input, and maybe we can choose 1, 2, or 3 of these goals and try to do our best. Regarding new businesses, in the July meeting, the Louisville Metro Public Health and Wellness Board of Health will elect a new chair and vice chair for the year 2026 to 2027. We're already talking with some candidates, but if you think of yourself as a candidate, please let us know. You have to be a board member. I'm sorry. Yeah. And these board members have been appointed by the council and approved by the mayor. Thank you, everyone. Thank you, everyone, for participating. Thank you so much for taking your time at this month's meeting. The next meeting will be held on Wednesday, April 1st at 8 a.m. It will be a virtual meeting. Please expect emails, and if you have questions, just don't hesitate. Just share your ideas, your questions. We can do great things. I mean, these great minds are working really, really nice. Is there any further businesses? And if not, the meeting is officially adjourned. Thank you very much. Appreciate it.
Thank you.
Thank you.
Please get yourself a snack or coffee or.